Welcome everyone. This is Ranvijay Kumar from Microsoft. I'm a program manager in Azure API for FHIR team. Our team builds Azure API for FHIR, also in open source FHIR server for Azure. And the broader team also works on DICOM server for Azure and IOMT connector for FHIR. So today we'll be talking about de-identifying healthcare data for research. So just a note on this topic, since we are talking about de-identification in healthcare, we fall under HIPAA purview. But just a note that this session is just to give you an overview of HIPAA guidelines for de-identification. It is not a legal advice, and if you need a legal advice on HIPAA, please contact your legal team in Microsoft CELA for legal advice. Please keep that thing in mind, because in the legal world, even a single change in the word or comma can make a difference in the meaning. So I just want to give a caveat on that side. So today's agenda, we will talk about HIPAA guidelines for de-identification at high level. Then we will talk about what kind of different data formats we see in healthcare and what is new in FHIR, which is a very common and very popular healthcare data standard now. Then we'll talk about FHIR Tools for anonymization. This is an open source project from our team, and how this helps in de-identifying FHIR data for different secondary use purposes, such as analytics and research. We'll also look at some other tools that are available for anonymization. Finally, we'll look at some of the research opportunities that exist in this area, and if we have those kind of solutions, then this technology can be, or this area can be improved significantly. And we'll have some time for Q&A towards the end, but at the same time, if you have any question, please feel free to put it in the chat window, in the Q&A window, and either one of the moderators will answer those questions, or I can have a look at it and answer those questions. Anyway, towards the end, we have some time for Q&A. So let's first talk about HIPAA guidelines for a de-identification of healthcare data, right? So if you're not familiar with HIPAA, like it's a U.S. federal statute. This was signed in the Clinton administration, 1996, and the purpose of HIPAA when it was created was to allow a flow of healthcare information, not to restrict information, but to allow healthcare information to be shared while protecting from fraud and theft. And that's why HIPAA goes into the details of like what kind of changes, how you should de-identify the data so that you can share it for various purposes, not only the patient care, but also research and analytics and things like that. And HIPAA is a US standard, US statute. Now, different countries, depending on where you are, you may have your own local regulations, and you should look at those before working with the healthcare data, or if you want to use it for research purposes. But the framework that I'll be talking about today is primarily around the HIPAA compliance. So let's look at some of the keywords that HIPAA uses in order to draw this framework. So first of all, it's the PHI. And PHI stands for Protected Health Information, not personal health information, as some people may believe. And what HIPAA does is it protects individually identifiable health information. So it's important to have a distinction between PHI and PII here. PII is a common term, it's personally identifiable information. But if you have health information associated, health information linked or linkable with PII, then it becomes PHI under HIPAA. The idea is that someone's health information should not be used to identify that person, because that results in healthcare data breach, and that has several legal consequences. So, so HIPAA cares about PHI. Now, one thing to keep in mind is that it's past, present, or future health information. It's not just what has happened in the past or what is happening right now with regard to the person's healthcare, but also future in the sense that if you're making any prediction, or let's say if you're doing a research and you realize that, hey, this particular person is likely to have this problem in future, right? That is covered under PHI. That becomes a PHI, and that is covered under HIPAA. So you are not allowed to, share that information. You have to follow the HIPAA guidelines for that. And when we say that healthcare information, it actually means that physical, physical health, mental health, or any kind of condition, it relates to the health care of the individual as well as the payment of the healthcare. So whether it's directly related to healthcare or it's related to the payment related to that healthcare. So that also falls under PHI. At the same time, one thing to keep in mind that if it's not linked to health information, then it may be PII but not PHI. What that means is that let's say there's a hospital or somewhere, they publish a list of patients. I'm taking a hypothetical example. They publish a list of addresses of people name and all those things out of context, and it has got nothing to do with healthcare. In that case, that list, it is PII, but it's not PHI. So that is something to keep in mind. But if the hospital says that, okay, these are the list of people to whom we have provided, patient care, that becomes PHI, because now you're linking to healthcare and saying that, yeah, these people were at this particular hospital at some point in time. The second thing to keep in mind is the primary versus secondary use of health data, right? So HIPAA uses these terms. These are HIPAA terminologies: primary use of data and secondary use of data. Primary use, anything related to the patient care. So provision of healthcare or payment with regard to that provision of healthcare. That is a primary use. Now, secondary use is anything that is other than the primary use. Things like your planning, quality control, public health reporting. You want to do research, analytics. All these become part of secondary use. So these terms become important as we go forward, and that's why it's important to keep this thing in mind. Now, the other thing is something called a business associate in HIPAA terminology, right? Now, business associate, before we understand that, let's think what is a covered entity, right? At high level, a covered entity under HIPAA is a healthcare provider or a payer. Provider is the entity that provides healthcare. Payer is the entity who pays for the provision of the healthcare services. Now, a business associate, it could be a person or organization or anyone, right, who provides services to the covered entity. Now, a business associate may receive PHI. So let's say if you are a researcher or if you are doing some analytics of the data under BAA, so there is something called a BAA, that's business associate agreement, that a covered entity may have with you as a researcher or as an organization. So the covered entity may give you access to PHI under BAA, right? But the BAA needs to be very, very, I would say the BAA needs to allow you to use the data for that particular purpose. If the BAA does not allow you to use the data for the purpose or the kind of research that you're doing, then you cannot use that PHI to do your research. So although it's a safer method, like receiving the raw data, identifiable data, perhaps from the research perspective is the best because you get all the information, but you need to be very, very careful about it because you need to have a BAA and the BAA needs to allow you to do the work that you are doing, right? But if you want to do anything outside the BAA, then you can only access de-identified data. And the good thing is HIPAA also tells like how you can go about de-identifying data. So they prescribe, and we'll talk about that. So in a way, de-identification supports secondary use of data. It makes it more easily available, the data more easily available, but that doesn't mean that you must de-identify the data in order to do research. You can do research under BAA also. Now let's talk about HIPAA privacy rule de-identification methods. So as part of the privacy rule, they also have specified what are the acceptable de-identification methods, right? At high level, they say two things, like there are two ways in which you can do it. One is what they call expert determination method, right? And the second one is safe harbor method. Expert determination method is like there is an expert, a statistical expert, and that's a loosely defined term. And we'll talk a little bit about that too. And so you can apply some statistical principle and make some changes in the data and determine that, yeah, there is not much risk or very small risk that the recipient will be able to reverse engineer or re-identify the individual, right? Now, keep in mind that there is a small risk that is acknowledged here. So HIPAA does acknowledge that there is always a small risk of re-identification, they don't expect that the data that is de-identified it has zero risk, in other words, right? So that's one way of doing it. The second way is a safe harbor method, in which there is a prescribed list of identifiers that need to be removed and from the data. But there is an additional clause there. It says that whoever is releasing the data, they should not have actual knowledge that the residual information can be used to identify individual. So if you notice here, what this means is that you can follow all the guidelines that the HIPAA has provided. You can remove all the identifiers, but at the same time, you have to use your own judgment whether the information that you're releasing or they're releasing can be used to re-identify the individual. And if you think that it can be, then you as the person who is releasing the data should be going ahead and releasing that. So in a way, it provides a framework for de-identification. It acknowledges risks. There is a subjectivity involved here. So there are some standard ways of doing it, but at the same time, there is subjectivity. But HIPAA also says that once you have followed one of these two methods, in that case, the data is no longer PHI, right? So which is great from a research perspective, that there is a prescribed way of doing it, and once you receive the data, it's no longer PHI. It can be shared broadly. Also, in some cases, it may be needed to re-identify the patients or re-identify people, and HIPAA allows a re-identification with the use of some kind of key. So the person who is deleting, the entity that is releasing the data, they can have a re-identification key, which can be used to re-identify the individual in some cases. For example, let's say you do a research and realize that here is a bunch of people, or here are the bunch of persons who can be who are susceptible to some risk, right? And it's very, very obvious from your research. You may want to go back to the entity that released the data and say that, hey, these are the people. Maybe you should contact them or call them for some kind of test or something. So and they may have might have retained a key using which they will be able to re-identify people. So re-identification is allowed, but at the same time there are certain caveats, like you need to maintain the key properly and things like that. So let's talk about one of these. Both these methods one by one. The safe harbor method, as I said, like it provides a list of 18 identifiers. So there is a complete list available on HIPAA website, and these are some examples of those fields. And these fields, if you notice here, like it's an exhaustive list. At the same time, these fields need to be removed not only for the individual, right, but for the relatives and employers and household members of the individual, right? So in your database, like if you are the custodian of the data, in your database, any information you have about the relatives, employers, household members, all of these fields must be removed, right? But Out of 18 fields, they say 18 fields, but the 18th field actually is, it just says that any other unique identifier characteristic or code, which pretty much leaves again the responsibility on the custodian who is releasing the data to make sure that you understand your data and make sure that in your data there is no other unique identifiers in some other field that's not one of these fields that can be used to re-identify the patient. At the same time, one of the confusions people have here is that do we need to remove the identifiers of the providers and healthcare workers, right? And HIPAA says that that need not be removed. So if a person goes to a particular hospital, meets a particular doctor, you need not remove the doctor's identifiers or healthcare worker identifier, which if you see from one perspective can be a little risky. Again, this is my opinion. I'm not a legal person, but this is my opinion that it can be a little risky because imagine someone going to a healthcare specialist, and which is a specialist in a very rare scenarios, rare cases. There are very few people who go to that specialist. So that information can actually be a little risky to release, but at the same time, HIPAA doesn't mandate you to remove that information. Of course, here the actual knowledge clause or some other clauses that they have may be used to hold you responsible that whether you should have released that data or not release the data. But as per HIPAA, that identifier need not be removed. So that's what the safe harbor method does. The other one is the expert determination method. Now, the question is who is an expert? And that is loosely defined. HIPAA doesn't say that, OK, you need to have a particular degree in statistics or anything in order to be called an expert. It just says that you need to have a relevant professional experience to, and you should be able to prove it. So I don't think anyone who is releasing the data or who calls himself an expert needs to, provide some kind of a degree or certification at the time of releasing the data. But if there is a case, my guess is that if there is a scenario in which data is breached, in which case they may have to prove that, yeah, you were an expert and you understood what you were doing. But it is a loosely defined term, right? And the expert determines, that there is a low risk in releasing the data. Now, it's not just a matter of, the statistical method and making sure that, there is not much distinguishability or knowability involved here, but also the expert may have to consider that what kind of knowledge the recipient has, right? What kind of prior knowledge or what kind of publicly available knowledge is available that can be used to link this healthcare data in order to re-identify the person. So expert may have to assess those things also. Here, the recipient of data plays an important role. So depending on who the recipient of the data is, the level of risk may be assessed differently by the expert. So it's not like, someone says that this data is de-identified and it can be widely available. Maybe it can be done. In that case, perhaps the level of de-identification that they would do will be more stringent than otherwise. At the same time, whatever approach you take or whatever approach the expert takes to de-identify the data, you need to have proper documentation and method in place so that in future, if there is a requirement to go back and assess, like, why did we have a data breach? In case of data breach, then you should be able to go back to the documentation and say what kind of analysis we did and whether we're missing something or improve something. But this kind of documentation and logging is very important. At the same time, there's one more clause involved there that the expert may put a time limitation on de-identification, saying that, OK, this de-identification is valid for 1 year or 2 years or whatever, and after that, this data should be deleted. And the reason we have this kind of clause is that, some kind of information may become publicly available in future, which can be used to link this data. That can be one. The other thing could be that, let's say you have some hashing of some values, or encryption of some values, and in future you have more powerful computing available using which you can, reverse engineer those values, right? So so there is a provision for time limiting the de-identification as part of the expert data emission method. So the next I want to talk about, since this isn't about the healthcare data de-identification, I want to talk about what kind of data do we see in healthcare typically, and also a little bit about FHIR. Now, in healthcare, there are several standards for data, depending on not only, it also depends on which country you are from. We have seen that in different countries, different standards are more popular. Depends on the purpose, like whether it's a hospital setting, or it's a payer setting, or a clinic setting, and what kind of information you're sending. So depending on all those factors, there are several standards in play here. Like the most common format that is available in healthcare is HL7v2, right? That's used in hospital settings, perhaps the most commonly used format. The next one was HL7v3, which was a completely different approach on HL7v2. By the way, HL7v2 is what we call a pipe and hat delimited format. It's a delimited format, you delimited by different characters. HL7v3 was the next take on healthcare standard. It has a very limited adoption because of the complexity involved there. It was XML format. So HL7v2 and v3 are used primarily on the provider side. The X12 is used primarily on the payer side, that is the claim processing. Now, there were efforts to consolidate healthcare information at the patient level, and there were several efforts. So there were things like CCD and C32 for generating patient health summary, so that you can have one document in which the entire information or the relevant information about the patient's health is captured. There were several efforts at that time, I think about 10 years ago or so. And again, what happened is that we had lots of competing standards over there. So CCDA come into picture. The CCDA was called Consolidated Clinical Document Architecture. And here the consolidated refers to the consolidation of standards, not consolidation of patient data. So which was interesting because there were so many standards that they came up with one standard, which is a consolidation of different standards to generate a patient summary, which I think is quite popular now, and it's also been mandated by government in the US. So then you have DICOM standard for exchange of medical images. Nowadays, IOMT, Internet of Medical Things, that's catching a lot of traction. And again, here there is no standard as such because different device manufacturers, they are coming up with different way to share the data. In future, I expect that there will be some standards coming in, but currently there are not popular standards available there. And then you may have lots of custom formats available in the CSV and relational data structure, different EHR vendors or different entities who are working on this. They may have custom formats here. And finally, FHIR, which has become quite popular since last few years. And there is a lot of blessing from government as well as enterprises to this standard, where people are trying to convert or use FHIR as the de facto standard for data exchange. Microsoft has Azure API for FHIR. Like, we have taken a bet on FHIR. So we have a complete ecosystem around FHIR technology. So we have a FHIR server that can be used to store FHIR data as well as access FHIR data. We have FHIR connector and converters to convert a different type of healthcare data. And let me show that to you in my next slide. So here it's just a sample of different type of healthcare data. If you notice here on the top left-hand side, we have HL7v2 messages and what it looks like. It's completely pipe delimited, and there is you may notice a caret characters called hat characters, very difficult to read and understand. At the bottom, you see CCDA message. It's XML-based message. As the network bandwidth increased, like the readability of the message increased as well. So earlier, people were trying to pack as much information as possible in one, one document without much semantics. But later we have XML messages coming in, CCDA, and now we have FHIR, which is even more readable and machine readable as well as human readable message. So FHIR is it's not only a data format where different types of resources, as it is called in FHIR, different type of entities, healthcare entities are defined and their schema is defined. It also has an API using which you can access the data. And it's a very, very live community, very popular. It's increasing in richness over a period of time. It's becoming more and more rich, getting lots of adoption. So from Microsoft side, we have a rich ecosystem around FHIR. So we have in the center, we have Azure API for FHIR that allows you to not only store the FHIR data, but also access it using FHIR API. We also have a DICOM server, which can take DICOM data, and there's a technology called DICOM cast that we have built, so which can take metadata from FHIR and load it to Azure API for FHIR. We have IoMT connector, so again, which can read different types of IoMT data and then convert that data into FHIR format. We have FHIR converter that can take different type of HL7v2 and CCDA messages and convert it to FHIR. So if you notice here, what the story that we have is that we take data from different formats and convert it into FHIR and use it as FHIR in the FHIR store. Now, we have built what we call a FHIR Tools for anonymization, which basically can take the FHIR data and anonymize it. Now, instead of going and trying to anonymize data in different data formats, what we have done is we use the infrastructure that we have, the ecosystem that we have that built to convert the data into FHIR format first. And then we have one tool that we can use to de-identify the data and then use it for a different type of secondary usage. Now, this de-identification that we do, we use the safe harbor method. So we aligned ourselves with the HIPAA guidelines for safe harbor method, and I'll show you what that does. So it's FHIR Tools for anonymization. That's what we're going to talk about in this section. So it's an open source project. It's available on GitHub. If you search on internet, you should be able to go there. It's a rule-based system where you can specify what data that you, and if you notice here in the previous slide, the FHIR Tools for anonymization on the right hand side, it takes a config file. So it takes the config file, and the config file defines how you want your data to be de-identified. So it takes the config file and it takes the FHIR data and it produces a de-identified FHIR data. So it's a rule-based system which uses FHIR path navigation language. So FHIR path again is a FHIR standard that allows is similar to XPath or JSON path in a way, where you can specify what elements of the data you want to alter. And we also provide, as part of the project, we also have a sample config file that is aligned with the safe harbor method. And the reason I say it's aligned because of the 18th field that we talked about. So out of the in the safe harbor method, they mentioned 18th field. 17 fields are pretty much well defined, where things like name and all, but the 18th is anything else. So which makes it very difficult for us to come up with a configuration file that would work for all the scenarios. It completely depends on the data custodian, like how what kind of data they have in the data set and which fields they need to alter. So we provide a sample config file, which is a great starting point, which will work perhaps 80% there or 90% there. But you should look at that, look at your data and review the result before using it in production. So we provide a sample config file. And what it does is it provides you a set of transformations that I'll show in the next slide. And those transformations, the rich transformations, can be used in the expert determination method. So for example, if you're using expert determination method and you decide that these are the fields that I would like to alter. So in that case, you could use these transformations of the config. You can create a config file, and that config file is based on your expert judgment. And then you can apply that config file to transform the data and de-identify the data. By the way, this technology, this de-identification capability is also integrated with the Azure API for FHIR. So once you deploy Azure API for FHIR, we provide you an endpoint, and then you can provide a config file as part of the API call. And then the data that comes out of the Azure API for FHIR is de-identified data. So it is part of the FHIR also has this concept of data export. So so we call it de-identified data export. The good thing about it is that your data, it never leaves or identifiable data, it never leaves the FHIR server, right? If you want to just share it for research purposes or secondary use purposes. So and that's the benefit of integrating with the Azure API for FHIR. The current limitation that we have is it does not support de-identification of unstructured text, but this is something that we are working on, and we should have this in future. Let's look at some of the transformations that are available as part of the FHIR tools for anonymization. So we have things like redact is just for removing all the elements. Date shifting, now that is an important transformation. So here what we do is we shift all the dates by a random value within a range, right? And the reason we have to shift all the dates is to maintain the chronological order, because we don't want to randomize the date. We don't want to give a medication before a problem or condition occurred. So in order to maintain that chronological ordering, we shift all the dates by the same amount, but that amount is a random amount. Now, that can be done at the individual patient level or can be done at the entire data set level. Then we have things like perturbation. So we can perturb or change the numeric values a little bit. We can hash it, encrypt it. You can substitute it with some fixed value. And you can also generalize the values. So generalization means that, OK, moving the values or replacing the value with a higher level of abstraction. Things like if you have, zip code or postal code, then you could just trim some of the, replace some of the last few digits with zeros. Or if you have even numeric values, then you can, round it. So these are examples of moving the value to higher level of abstraction, or things like if you have, city level information, you can move it to a higher level, like say the district level or county level information. So these are the capabilities that are available. Let me quickly show to you like what this tool looks like. So this tool, as I say, the FHIR tools for anonymization is available in a couple of ways. It's available as part of the Azure API for FHIR and the FHIR server for Azure. So it's an API call. You can make that to identify your data. It's also available as a command line tool. That's what I'm going to show you now. And also there are ADF pipelines available, Azure Data Factory pipelines available, using which you can de-identify your data. So this command line tool, it just takes a few parameters. So before I do that, let me show you the kind of data that I have that I'll be de-identifying. So if you see here, I have some samples, sample data here. Like these are FHIR data. So if I open it and I have it open in Visual Studio Code here. These are some sample files, and this is what the FHIR data looks like. It's a JSON file. So I have 4 such files in a folder, and I'm going to use a config file to de-identify the data. And let's say look at the configuration that we have. And the configuration has basically two sections. One is the FHIR path rules, where you could specify using FHIR path syntax what you want, what kind of operation you want to do on those fields, whether you want to keep it or hash it or redact it. And this rule is read from top down. So first this rule is applied and then the next rule is applied in order to avoid conflicts. The FHIR path syntax is quite flexible in terms of you could give nodes by type. So not only you can give the nodes by name that these are the fields, but you could also specify that all the data types, all address types need to be affected in a particular way. Here you can say you can apply an OR syntax like date or date time or instant. You want to date shift. So you can have this configuration. This configuration is just for demo. This is not the sample configuration that we provide as part of our safe harbor method. That configuration is much more richer. And if you see here, you can provide the keys for date shifting, hashing, and all. You can specify the scope for date shifting. These are the zip codes. One of the HIPAA guidelines says that for safe harbor method, if the population of a particular zip code is less than 20,000, in that case, you are supposed to remove the last 3 digits. Not remove, basically replace those last 3 digits by 0. And it turns out that these are the only zip codes in the US that has that population. So this just tabulated here. But if you want to make changes to that, you can definitely do it. So let's look at the tool. So what this tool does is it takes if you look at this is the exe, it's taking the config file and it's taking the input folder and the name of the output folder here. And once I run it, it'll take some time. It's giving me a warning, but that's okay. That's okay. We can ignore it. And it should produce the anonymized files or de-identified files. Yeah. Now, if I open these files just to see the difference here, and I'll pick this two files to compare in the anonymized folder and the sample folder. So I'll just use it for compare and it'll take a few moments to compare here. So what we do is that we are producing a de-identified FHIR resources, and as part of the FHIR specification, we are supposed to specify what kind of changes we have done to the original data so that the recipient knows that, hey, this is not the real data, but these are some of the changes that are done in the data. If you notice here, we are changing the ID based on the configuration. Some of the fields are getting removed. Some of the identifiers, again, based on the HIPAA's safe harbor method recommendations. So these things are getting removed. Notice the date is getting shifted. So this was the original date, March 27th. That is getting shifted to May 2nd. For address, most of the fields are getting removed except the postal code, again, based on the same configuration that I showed to you. So this is how it works. So this is, at this point in time, it is a rule-based system, but it's foundational in nature in the sense that we can build a next level of intelligence on top of this and use these foundational capabilities to do the data identification. So currently, this configuration is created based on the safe harbor method, or if you're using expert determination, in that case, the expert is going to create the configuration. But if you build a next level of intelligence on top of that, that's what we want to work on next, then this configuration will be generated using that intelligence. So we have about 15 minutes left, so I'll quickly go through the couple of other slides that I have. These are some of the other solutions for de-identification. So there is for healthcare data doing very similar to what we do. So Google has data de-identification as part of their Google Cloud Healthcare. It's also a rule-based and it uses ML model for unstructured text and images. And these are some of the other tools that are commonly used in healthcare. Most of these tools they work on tabular data. And that kind of puts a limitation on when you want to de-identify the FHIR data, because FHIR data is not tabular data. It's a JSON data and hierarchical data. And if you, the moment you move to tabular, either you end up with a very, very complex data structure, or you end up with some data loss. And that makes it a little difficult to use most of these tools. But these tools are used in a restricted way. And if you're focused on one particular data set with restricted fields, then these are some of the fields. These are some of the tools that you can consider using. Now let's talk about some of the opportunities that we see in this area. So one is, it'll be great to have something like a differentially private FHIR data store, or because and that's a very difficult and a complex problem, because in differential privacy you have this concept of budgets and all. And the more query that you make, the more information that the recipient gets on differential privacy, the risk increases. But if there is a way, again, it's a wish list. If there's a way in which we can come up with a way to de-identify the data that guarantees certain level of privacy without losing useful information, that would be great. De-identification of unstructured text, I think that's an interesting area, because what happens is that in healthcare, or not only in healthcare, anywhere, if you have unstructured text, identifying entities is very, very domain specific thing. So, and there is no one algorithm that will be able to identify entities in all the cases, in all the scenarios. So there is an opportunity, and in healthcare especially, there is a very less tolerance for false negatives, right? So so there is an opportunity here for so many different healthcare domains, and what we have noticed is that different domains require different level of treatment of these unstructured text. Now, de-identification of DICOM images. Now, interesting thing about DICOM images or X-rays or CT scans is that not only these contain PII embedded within the images, that is the name of the person and things like that, which is a relatively simpler problem, because you can use some kind of algorithm to maybe OCR it and identify the text, and then apply the same rules or unstructured text algorithms to detect PIIs within images. But these images in themselves can be used to re-identify the person. For example, the X-ray of a person, it has the shape of the face there, right? Or the shape of the nose, or things like that. And that is potentially that can be used to identify the people. So that becomes an interesting problem. And it needs to be changed or altered or de-identified in a way that it does not take away the meaningful information, the information that a researcher is actually interested in studying and analyzing. So that's an interesting problem. Similarly, de-identification of IOMT data. So IOMT data is a devices. You're getting lots and lots of data from devices. And if I remember, like this few years ago, there was a competition on Kaggle that asked people to re-identify. The task was to re-identify people using the sensor data from smartphones, right? So, and there were winners there, and there were success there. So the idea here is that the IOMT data has so much signal that it can be used to re-identify people. But again, the same challenge here is that how do we de-identify IOMT data so that it doesn't lose its meaning, or whatever the relevant, the useful information is there. At the same time, it alters the data in such a way that it's not identifiable. Okay, so that I think is a good opportunity there, and of course synthetic data generation. So again, it's interesting. The same challenge there. Like, how do you generate synthetic data so that it produces similar result that you would get on the real data, right? And so there are several approaches there. I mean, several algorithms, several people are trying it. But there, when we talk to data scientists or when we talk to people in healthcare industry, they would prefer to work with the real data rather than the synthetic data, because they are going to spend the same amount of time, the same amount of resources, and if they do not have guarantee that it's going to give them similar results, they're a little hesitant to use synthetic data. But there is an opportunity here to generate synthetic data from the real data, and if there is some kind of guarantee there that it will produce similar result, I think that would be great. Towards the end, I'll just leave with some resources here. So if you have access to the slide deck, you will be able to click on these resources. So you have FHIR specifications and Azure API for FHIR. You should be able to search for these on internet and access these resources.